Hello, I'm Dr. John White, Chief Medical Expert at Discovery Channel. Minimally invasive endoscopic orbital surgery is an innovative approach that often improves a surgeon's visual field and avoids craniotomy. At UPMC, a multidisciplinary approach is used for hemangiomas, melocytomas, infections, and other orbital pathologies. Let's learn more.
There are a lot of masses or pathologic processes in the orbit that are easy to get to because they're very anterior or because they're lateral, where we can just take off a piece of bone and put it back when we're finished. But the important stuff in the orbit tends to be sort of very posterior and medial. And we can protect that and see the pathology without harming the normal structures if we use endoscopes to either come transnasal and look lateral into the orbit, or actually come into an orbital wound and look posterior that way. The traditional approach is to take the lateral wall of the orbit off to give the eye room, and then pushing the eye laterally. And just like in neurosurgery, you don't want to put traction on a neural structure if at all possible. So if we can actually approach the tumor or the process from right where it is and land on that first instead of landing on the optic nerve first and having to move it out of the way, then we're going to be a lot safer and we're going to disrupt the normal anatomy a lot less. So the people who are good candidates for this are people who have masses or processes in the orbit that extend from about the mid portion of the globe posterior, and then superior, medial, and inferior. These are traditionally not well approached by other types of surgery. We also do well with masses that are intraconal because they sort of create their own corridor between the extraocular muscles. What's pretty unique about doing the endoscopic orbital surgery at UPMC is we have a team approach, and we're very used to working together because we've worked together for years. The otolaryngologist's job is to do the sinus surgery and give us visualization looking laterally. The ophthalmologist's job is to orient everybody in the orbit and be able to identify what structure is what. And the neurosurgeon's job is to do a lot of drilling and to protect us from getting into the brain. So we take the patient to the operating room, put them to sleep, and we register our image guidance system. The sinus surgeon goes in and does what is in general pretty traditional sinus surgery, and then takes down all the septations of the ethmoids. So when he looks laterally, he sees the medial wall of the orbit. We take down that bone, which is very easily taken out with just a ball probe, and we open the periorbita, which is the membrane that keeps everything in the orbit. We see fat and muscle, and at that point we start manipulating the eye and the muscles so that we know where to cut between the muscles. And then we land on the pathology that we are hoping for, and we either biopsy it or we remove it. The benefits to the patient are, the two main ones are that they avoid a craniotomy. So in general, their hospital stay is less. Most of them go home the next day. The other benefit is that we approach the pathology first, and we use that to protect us from the structure that's the most delicate in the orbit, which is the optic nerve. What physicians should know about the endoscopic orbital surgery is that it's a good option for patients who have masses that are particularly mainly from the midpoint of the globe posterior, and then medial, inferior, and superior. Other things we have good approaches for laterally, but these we in general don't.
The endoscopic approach to orbital surgery offers patients a minimally invasive alternative to treating many complex diseases of the orbit. By using a multidisciplinary approach, patients benefit from the combined knowledge, experience, and technical expertise of the entire team to help ensure a favorable outcome.